give it another couple of minutes just to give everyone a chance to dry before we start. All right. Right, it's about 10 past, so we'll make a start. Hello everyone, my name is Will. I'm one of the MindTheBleep trauma orthopaedics leads for this year. And this evening we're going to be going through the hip as far as it relates to orthopaedics. So let's get started. Okay, so when we talk about the hip, there's quite a lot to cover, but the main 5 things that will come up in UKMLA, or that are important to know at a medical school level, we have written here. We've got 3 traumatic conditions, obviously the biggest of which is going to be neck of femur fractures, but it's also important to touch on pubic rama fractures and fractures of the femoral shaft or femoral diaphysis. Additionally, in terms of elective orthopaedics, the big topics are going to be osteoarthritis and greater trochanteric pain syndrome. So starting off, thinking about hip pain in general, it's a really common presentation that is going to be really going to turn up to the GP for, and therefore it's going to be a very common thing that GPs are going to refer into the orthopaedic service. But the really big thing is a lot of people get confused about hip pain. So true hip pain, being caused by pathology of the hip, is felt in the groin or in the buttock, round about the level of the gluteal fold. Pain in the lateral thigh is very unlikely to be true hip pain in origin. A lot of people think that's where the hip is, especially when they're feeling over sort of the greater trochanter area. But it's very important to distinguish between true hip pain and cause of lateral thigh pain. Very often hip pain can be referred to the knee, and this is most commonly seen in the extremes of age, so the very young or the elderly. And it's always really important whenever you come across hip pain to consider the spine as well, because you can have referred pain from the spine down into the groin. So we'll start off with orthopaedics, so with some good anatomy. Looking at the anterior view here, the important structures to note is the femoral head. This is the articulating surface with the acetabulum. It's covered with hyaline cartilage. If there's an area of cartilage in contact with the acetabulum, it's known as articular cartilage. Other important structures, we have the neck of the femur, and we have the greater trochanter, which sits superiorly, the lesser trochanter inferiorly, and connecting them anteriorly, we have the intertrochanteric line here. The trochanters are big sites of muscle attachment. We'll come on to a little bit of that later on. Important structures on the posterior aspect, we have the fovea. This is the site that the ligamentum teres attaches from the femoral head into the acetabulum. You can obviously also see the head and the neck from this area. And the posterior side, you can see the greater trochanter, the larger part of the greater trochanter, as well as the quadrate tubercle. the lesser trochanter, inferior again, and connecting these instead of the intertrochanteric line is the intertrochanteric crest. One more point of anatomy on the posterior aspect that's useful to know about is this here, the linea aspera. So there's a lateral and a medial lip, and these are rough areas that serve as sites for attachment of muscles, specifically on the posterior aspect, the hamstrings, all the way down the femoral shaft. So important neurovasculature. We'll start off with the arteries. So the big artery is, of course, the femoral artery. Now this originates from the anterior superior iliac spine and inserts at this point here on the pubic tubercle. Once this artery crosses that line, it becomes a femoral artery. Before that, it's the external iliac artery. This is going to supply the profunda femoris, the deep artery of the thigh, and it's also going to travel down through the adductor hiatus and become the popliteal artery behind the knee. Other important arterial structures is this here, the lateral circumflex artery. So the profunda femoris gives off both lateral and medial branches, and these form a ring around the top of the femur here, coming around the greater tubercle. Now, why that's important for us in orthopaedics, specifically for the hip, is because of these structures here zoomed in. So the lateral circumflex artery gives off perforating branches which travel up to the base of the femoral neck, then travel from the femoral neck up to the femoral head. Now, we'll have a quick go to see if we're going to get any answers in the chat. But does anyone know what the term for that kind of blood supply is? Okay, so this is a term of retrograde blood supply. And the reason this retrograde blood supply in the femoral head is important is if you get a fracture towards the base of the femoral neck along this line here, it's going to disrupt the blood supply not just to that area, but also to the remainder of the femoral head more proximally. That's important because if there's any displacement in that fracture, these blood vessels will be at risk, and the femoral head itself is at risk of avascular necrosis, so death by lack of blood supply. Moving on to a couple of the key nerves in this structure. The femoral nerve follows the femoral artery down into the anterior canal of the thigh. That's going to supply all of your anterior thigh muscles. And importantly, not for the hip itself, but in hip surgery, is this, the sciatic nerve. And the reason the sciatic nerve is important is if you look in this area here, it runs posterior to the femoral head. So especially in hip arthroplasty, hip replacements, if you're using a saw blade to cut through the femoral neck to remove a fractured or damaged piece of femoral head, there's a risk of damaging the sciatic nerve which sits behind it. And that's why surgeons are often very careful not to breach that cortex with too much force, because it increases the chance of damaging the sciatic nerve. One last quick point of anatomy before we move on, and this is more relevant about hip fractures, but the joint capsule. So the joint capsule extends from the acetabulum all the way down to the base of the femoral neck. So this is the anterior view, this is the posterior view here. And that's going to become important in just a second. Other important structures in the hip, we have the acetabulum here, and then we also have the acetabular labrum. The labrum is fibrocartilage, and that helps to deepen the hip socket and allow for a better fit of the femoral head in the acetabulum.
So when we're looking more at neck and femur fractures, this is the bread and butter orthopedic hip knowledge, especially for the MLA. More common in old age, specifically more so in females than males. And that's mainly due to the fact that not only is neck and femur fractures associated with frailty, but it's also associated with osteoporosis. When we're looking at the risk factors for osteoporosis, the three most important factors are age, so old age, as we've discussed. Menopause, this is why neck of femur fractures are more common in females, because postmenopausal changes in the hormonal balances in the body, especially estrogen, can hasten osteoporosis, as well as steroids. So the important thing to note is that neck of femur fractures have really poor outcomes. About a third of patients will die within 1 year of sustaining their neck of femur fracture. A further third will not return to being completely independent or will not return to their functional baseline pre-injury. And only about a third of neck of femur fractures will return to their functional baseline. So if you're in the emergency department and you think someone's fractured their neck of femur, what are you going to see? Well, the classic presentations I'm sure many people will be aware of is a shortened, externally rotated leg. You can see in this image here, it's this right leg. You can tell by the heel here on the right foot, here on the left foot, and the toes are pointed out, which shows that the leg is externally rotated. The reason this happens is shown in this diagram here. When the neck of femur breaks, when it fractures, the gluteal muscles, especially gluteus medius, overpower the adductors and the internal rotators, and along with iliopsoas, will pull the distal fragment up, out, and will externally rotate. So the gluteals and iliopsoas are stronger than the internal rotators and the adductors. So when there's no bony continuity, these muscles overpower the others and result in this classical clinical presentation that we see here. Other clinical signs: pain on pinrolling a leg. So you the patient's leg and ask them to relax, and then rock that leg back and forth can help to elicit the pain, along with passive internal and external rotation. Obviously, internal and external rotation is going to cause pressure in this fractured area and is going to elicit pain. Very importantly as well, these patients cannot weight bear. Okay, so moving on. 3 main types of neck of femur fracture that we concern ourselves with. As we discussed before, it depends on their relation to the hip capsule. The first type that you can see on the furthest right-hand side of this slide is an intracapsular fracture. So in this diagram, we're looking at this left hip here. You can see the fracture line coming along here, but you can see that it is within the hip capsule. So the hip capsule will extend from the base of the neck of femur here up to cover the femoral head. The second type we look at is intertrochanteric fractures. So that's a fracture, as the name suggests, that runs between the greater trochanter superiorly and the lesser trochanter inferiorly. You can just see there's a fragment of the greater trochanter sat superiorly, and the lesser trochanter has been fractured off the femoral shaft. And finally here, you can see a subtrochanteric fracture. The difference between a subtrochanteric and an intertrochanteric is if you look in this area here, you can see that the greater trochanter, just here, the lesser trochanter are fully intact. So that fracture has happened below the line. And another quick and easy way to tell is that intertrochanteric fractures are often oblique, so they run diagonally, whereas subtrochanteric fractures are often transverse or horizontal. A quick point for more difficult to assess fractures, you can look at the Shenton lines. Sorry, I'm not sure what's happened to my slide formatting here. So a Shenton line, an intact Shenton line, should run up the medial aspect of the femoral diaphysis, the shaft, along the medial aspect of the femoral neck, and then be a nice smooth curve along the superior pubic ramus. You can see again here, this runs up the medial aspect of the shaft, the neck, makes a nice continuous line with the superior pubic ramus. On the right-hand side of this image, you can see an altered or disrupted Shenton's line, where it's running up the medial side of the femoral shaft along the femoral neck, but there's a break in continuity before it comes onto the superior brute ramus. If this is in younger patients with no history of trauma, this may suggest a developmental issue. But if you have a clear history of trauma, hip pain, unable to weight bear, but it's not massively clear on the x-rays, as previous x-rays were, having a look at the Shenton line can help to identify more subtle fractures. So how do we classify hip fractures? The main classification we use is shown here. This is the Garden classification. So it runs from 1 to 4. Garden 1 is an incomplete fracture that is undisplaced. And obviously, if you remember before talking about undisplaced, 1 and 2 versus displaced, the big significance of that is the blood supply. So undisplaced fractures, the retrograde blood supply that comes from the base of the femoral neck here is less likely to have been disturbed. When you consider these displaced fractures, it's clear that there'll be some disruption to the blood supply, and therefore the femoral head will be at risk of AVN. So Garden 1 is an incomplete fracture that is undisplaced. A Garden 2 fracture is complete and undisplaced. A Garden 3 fracture is a complete fracture that is what's called incompletely displaced. And this means there is still a portion of the femoral head that is in contact with the femoral neck, as opposed to a Garden 4, which you can see here, where it's clear there is a complete fracture and the fracture is completely displaced, in that there is no communication between the femoral neck and the remainder of the femur. So how do we go about fixing neck of femur fractures? Well, as you can see here, there's 6 main ways that we can fix fractures, and it depends entirely on where that fracture line is, based on those 3 types of fracture we talked about earlier. So first of all, we can use cannulated screws, which you can see here. We can use a dynamic hip screw, an intermedullary nail, and either a hemiarthroplasty or a total hip arthroplasty. So when do we use all of these? I'm sorry, it's a slight issue with the formatting, but cannulated screws are not massively commonly seen, and they're reserved specifically for intracapsular, non-displaced fractures. So there's no risk of avascular necrosis to the femoral head, the blood vessels are intact, and so all you do is fix that in place. That has the advantage of leaving the person's native joint intact, which is always preferable. Second of all, we have a dynamic hip screw. This can be used for intertrochanteric fractures, as we said, fractures that go through the greater and lesser trochanter. And the unique part about a dynamic hip screw is this portion here. This is the central portion, the barrel. It can compress and slide into the main area. That allows gravity to push the proximal femoral head and femoral neck against the distal part and provides compression as the person mobilizes. For subtrochanteric fractures, so fractures that go below the trochanters in that transverse plane, we want to consider an intramedullary nail. This is a rod that is placed up into the femoral head and also down the femoral shaft and is fixed at the end. Now we have 2 types of joint replacement that we see for people with displaced intracapsular fractures. It depends largely on their activity levels. So if you have a younger patient who has a higher activity demand, we would consider a total hip arthroplasty, so a total joint replacement. And this is probably the most common that you'll see. If we have a patient with very low activity demand, who's that bit older and perhaps less active, we can consider a hemiarthroplasty. And the difference is obviously we're always replacing the femoral component because that is the area that has been fractured. It's whether we replace the acetabulum as well. And the reason we would only put hemiarthroplasty in more elderly patients is it reduces the burden of the operation and increases their opportunity to recover. It's also very important to say that when you're fixing neck and femur fractures, the key to a successful outcome is fixing early and getting the patient into early rehab. And as with many patients, if this is an elderly patient who has fallen and fractured their hip, it's important not only to involve orthopedic care, but also to consult geriatrics. And there's very often orthogeriatric consultants involved in neck and femur fracture patients to ensure that the patient's orthopedic issue, but also the remainder of their issues, are addressed comprehensively. So moving on now to something a little bit different, which is pubic rami fractures. So the reason we're covering this is they can present in quite a similar group of people to neck and femur fractures. With pubic rami fractures, you're looking at elderly patients, often who've had a fall from standing height. These are patients that are postmenopausal in female, osteoporosis, and frail. The difference in the clinical presentation is that instead of pain on palpation of the hip joint, which, as we said, is in the groin, there's more tenderness over whichever of the pubic rami is fractured, and that is felt more medially than a neck and femur fracture. Other ways to differentiate from a neck and femur fracture is that the leg alignment is maintained. So as we said, in neck and femur fracture patients, you see that classic shortened externally rotated leg. In a pubic rami fracture, the heels will sit at the same point on the bed, and the feet will be pointing roughly in the same direction. Additionally, because there's no issue with the hip joint itself, there's no pain on pin rolling the leg, as we said, asking the patient to relax and rolling that leg back and forward. The management's also very different, so we don't often consider surgery in these patients, especially if they're elderly or if it's a low impact injury mechanism, such as a fall from standing height. We focus much more on full weight bearing, physiotherapy, and analgesia. So it wouldn't be orthopedics without some x-rays. One of the really useful things I was told when I was a medical student was to consider the obturator foramen on this side and this side as two polos. And the reason that's important is in pubic rami fractures, there's very often a fracture of both the superior and the posterior ramus of the pubis. So if you look at this image on the right-hand side here, you can see there's a quite obvious fracture here in the inferior ramus. But if you look closely, you can also see there's a fracture in the superior ramus here. So this comes back to that two polos I was talking about. In that if you have force entering at a point that will cause a pubic rami fracture, it will often exit across from that and cause a concomitant fracture. Much more obvious on this one. You can see a very clear fracture of the inferior and superior rami. But actually, if you look very closely, you can also see a fracture of the inferior ramus on the contralateral side, which is arrowed here. And moving on to our final of the three common trauma presentations in orthopedic hip, we're thinking about femoral diaphysis fractures, which obviously isn't a true hip pathology, but is commonly related. The diaphysis refers to the shaft of the femur, and as you can see from this diagram here, there's a lot of different morphologies, largely depending on how the force is distributed. Important things to know is that there's a bimodal distribution of patients that suffer femoral diaphysis fractures. In young patients, it's commonly associated with high energy impact, so things like motor vehicle accidents, falls from large height. And 5% of these, about 1 in 20, will have a hip fracture on the same side due to the excessive force that has caused the injury. Conversely, in more elderly patients, this is a much more low energy pathology. In a more low energy situation, it's less likely the patient will have a concomitant hip fracture. So what do we see in femoral diaphysis fractures that allow us to tell the difference between them and a hip fracture? Well, first of all, you're going to see quite a similar proximal segment as you would for a hip fracture. You're going to see flexion of the hip and abduction. And this comes down to actually the same muscles that were causing it in a neck of femur fracture. So the flexion comes from iliopsoas, and the abduction of the hip comes from the stronger gluteals relative to the adductors. What we're going to see in the distal segment is extension of the fracture segment as well as varus angulation. Now, varus angulation means that the fracture point is more lateral than the distal segment. The reason this is the case for extension is that gastrocnemius inserts onto the posterior aspect of the femur. So what you'll commonly see is that as that is then acted on unopposed, it may cause flexion of the knee, but the distal part of the femur will be angulated posteriorly relative to the proximal segment. And the varus alignment comes from the action of the adductors unopposed by the abductors. So the abductors obviously will focus around the hip, the gluteal muscles, whereas a lot of the adductor insertion is down the medial aspect of the shaft of the femur. So how do we fix femoral shaft fractures? So it's important to say, as we mentioned, that because this is quite a high impact injury, it's very commonly seen in polytrauma as well as in open fractures. So often patients will come in, as I said, from a motor vehicle accident, a fall from height, some other form of trauma, and there may be multiple fractures, which is not known as polytrauma, within the patient. Alternatively, there may be an open fracture, where the fracture point is in contact with the open air because there's been a break in the skin. In these instances, in the first instance, it may be important just to fix the fracture in place, so reduce it, because often there are other pathologies, abdominal trauma, head trauma, etc., that take priority over orthopedic management. So how you fix this is you perform a closed reduction using the emergency department, and you'd apply what's called an external fixator, which you can see here, which is often commonly called an X-fix. This is used to maintain that closed reduction in place while the more urgent issues are addressed, and this is then converted to one of these, which we saw earlier for the hip. This is an intramedullary nail. Now, if this is not a case of polytrauma or not an open fracture and the patient is stable, you can proceed straight to an intramedullary nail. This is definitive irrespective of what the cause of the femoral fracture is and has very good outcomes. About 98% of people who have an intramedullary nail have union, so fixation of the bone at 6 months. Once the patient has the nail fitted, they are free to fully weight bear, as the nail will take any of the excessive force. You can in fact see in this area here, this bulge in the bone is the site of fracture fixation and union. Usually the nails are placed what's called antegrade, so that's starting superiorly from just inside the greater trochanter and placed down. Sometimes the nails can be retrograde, depending on the indication. So coming on to the other big topic in hip orthopedics and orthopedics in general is osteoarthritis. So as I'm sure most of you know, osteoarthritis is the progressive loss of articular cartilage in any joint, but specifically in this case, in the hip joint. Now, how do we tell it apart from rheumatoid arthritis? Firstly, rheumatoid arthritis is not very common in the hip. It's more common in the small joints of the hands and the feet. But secondly, there's a lot less of an inflammatory component. So if you're looking at someone who's complaining of hip pain or in fact knee pain, and there's not a lot of swelling, there's very minimal erythema or redness, this is more likely to be osteoarthritis. Osteoarthritis of the hip is the second most common site after the knee. And risk factors for osteoarthritis include increasing age, being female, and a big indicator is pediatric hip pathology. So that's developmental dysplasia of the hip, Perthes disease, and what's called SCFI or SUFI, which is slipped capital femoral epiphysis. We'll cover more of that in our pediatric orthopedic session. So what is someone who's struggling with hip orthopedics going to come in and complain about? The main issue is going to be pain, and there is also some stiffness. Again, what separates osteoarthritis from rheumatoid arthritis is that the stiffness is quite short duration. When you compare that to rheumatoid arthritis, where often the stiffness goes on for several hours. The joint very well may look and feel normal, but if it doesn't, common things that you may notice is reduced internal rotation and extension of the hip, which can progress to what's called a fixed flexion deformity. And that is where the patient's hip is constantly held in flexion and they cannot fully extend that hip and so bring that femur down onto a bed, for example. They may be walking with what's called an antalgic gait or a painful gait, or you may see a Trendelenburg gait, which is shown in this image here. What happens in a Trendelenburg gait, so in this example, is when a patient plants their foot, so their right foot, their hip drops to the other side. And the reason that is the case is that the gluteal muscles, your abductors, which help to hold your hip steady when you plant your foot, are weakened. And this can be seen in hip osteoarthritis due to disruption of the architecture of the hip joint, affecting the length of the gluteal muscles and also causing inflammation and reducing their effectiveness. A late sign in orthopedics of any joint, but also in the hip, is severe joint deformity, and we'll go through why that is in a moment, and ligamentous laxity, so the ligaments become less taut and less strong, and that can then result in joint instability. The Trendelenburg sign here is a sign of joint instability due to the compensatory mechanisms of dropping that hip. So how do we classify osteoarthritis? We're classifying osteoarthritis, we're looking at tonus grade. So starting with grade 0 is healthy. In grade 1, we're seeing a slight narrowing of the joint space, a small amount of lipping at the joint margin, and that could indicate early osteophytes, and some slight sclerosis in the femoral head and in the acetabulum. And we'll look at some images of what these look like in a moment. As you progress through the grades, you're looking at worsening of the narrowing of the joint space. You start to see effects on the femoral head itself. It becomes less spherical. Pardon me. And as you start to get into grade 3, you start to see severe narrowing of the joint space, severe deformity, severe sclerosis, and it may even progress to avascular necrosis. So how does that look on images? As I said here, you can see sclerosis of the bone, which shows up as bright white areas just under the articulating surface. You can see it here, and you can also see it along the femoral head here. You see narrowing of the joint space. So if you look at the lateral edge of the joint here compared to the medial side, you can see there's almost contact between the bones. And you get development of osteophytes, which are bony overgrowths around the joint. So you can see osteophytes both ends here. You can see how this femoral head is starting to lose some of its sphericity, some of its circular nature. Coming over to this side, you can see further joint space narrowing. You can see that bright white bone sclerosis. You can see very clear osteophytes here as well. So how do we manage osteoarthritis? We start off with conservative management. So lose weight, increase exercise. If you reduce the amount of weight that's going through a hip, it reduces the pressure and can help to alleviate symptoms. As can physiotherapy, which can do things like strengthen muscles around the hip, help to offload some of the force through the joint itself. And then we can start looking into things like walking aids, so using sticks, crutches, four-wheeled walkers, anything that allows you to offload some of the force that's going through the hip and therefore reduce the symptoms. Other things like stopping smoking, eating a healthy diet, etc. can also be beneficial. After conservative management, we move into medical management. So things like anti-inflammatory drugs, so non-steroidal anti-inflammatories. And simple analgesia, things like paracetamol in the first instance. If that's still not controlling pain, then we would consider a short-term prescription of opioids. And after that, consider injecting steroid into the joint as an intra-articular steroid injection. Steroids are anti-inflammatory, and so introducing localized steroids into the joint can help to reduce joint inflammation and therefore the pain associated with that, while minimizing systemic effects of the steroids. And finally, when conservative and medical management have failed, this is when the patient is listed for a hip replacement, hip arthroplasty. Usually at this stage, there is damage both to the acetabular side and the femoral side, and so it would be a total hip. So finally, we're just going to touch on greater trochanteric pain syndrome. So this is a very common mimic of true hip pathology. If you remember at the start, we talked about differentiating true hip pain, which is pain in the groin or in the buttock, from lateral thigh pain, which can often be mistaken by patients as hip pain. So greater trochanteric pain syndrome encapsulates inflammation of the gluteal tendons at their insertion with the greater trochanter. You can see in this image, you can see the gluteal tendons inserting on the greater trochanter here, as well as inflammation of the trochanteric bursa, which sits here. Now, a bursa is any fluid-filled sac in the body that helps to either reduce the force going through joints or reduce irritation from tendons, etc., on bone. So you can see that this is in fact not going to present with true hip pain, which would be felt in here, but it's actually going to be present with pain in the lateral aspect here. Very commonly, greater trochanteric pain syndrome is secondary to abnormal hip biomechanics. So that can be some of those developmental issues we talked about earlier. It can be people limping if they have issues with their knee or ankle on the same side, or in fact even on the contralateral side. But any abnormal loading through this area is going to cause that irritation. Typically this is seen in 40 to 60-year-olds, so middle-aged people. And again, it's more common in females than males. As I said, this red arrow is showing where the gluteal tendons are inserting on the greater trochanter. So what's someone going to come in and describe if they have greater trochanteric pain syndrome? They're going to talk about pain in the lateral thigh. As I said, not true hip pain because it's not felt in the groin and buttock. And they'll describe it as worse when they're either exercising, because as you're causing those muscles to contract, it's going to further irritate irritated tendons. Additionally, the tendons will be sliding over the bursa, causing further irritation. And there'll also be pain by lying on the affected side, because that's going to cause compression on an inflamed bursa and inflamed tendons. Examination can look quite normal. The patient will be incredibly tender when you palpate the lateral hip over that greater trochanter, because that's the area of the inflamed gluteal tendons. And there'll also be pain when the patient is asked to stand on the affected leg. And that's for the same reason as we talked about when a patient presents with a Trendelenburg gait with hip osteoarthritis. Standing on your leg engages the gluteals on that side to keep your leg straight and will elicit the pain if they're inflamed. It's important to say that while it may be painful, the patient will have a normal range of motion, both active and passive. So it's mostly a clinical diagnosis. And as you can see from the previous slide, there are some quite key clinical signs and symptoms that would push you towards a diagnosis of greater trochanteric pain syndrome. An MRI is usually diagnostic, but it's very rare that an MRI is required. And you won't find any clinical signs on X-rays in these patients. Excuse me. So the management for greater trochanteric pain syndrome is mostly conservative. So advising patients to lose weight, referring them to physiotherapists to help with strengthening the muscles and also optimizing those biomechanics. So perhaps looking at ways to normalize the force being transmitted through the hip, addressing other knee and ankle pathologies causing the pain, for example, or considering walking aids and orthotics as well. Very similarly to osteoarthritis, medical management consists mainly of non-steroidal anti-inflammatory drugs, and if they're not effective, considering intra-articular steroids, which will reduce the inflammation in those gluteal tendons. Surgery is not routinely considered for these patients because there's nothing really surgically to fix. Pardon me. So that's everything I have to cover. If you have any questions, please feel free to pop them in the chat and I'll be happy to answer them now. Okay then guys, if there's no further questions, I'm just going to stop sharing my screen. So there should be a feedback link in the description for the session, everyone. If you could please fill that out, that helps us massively, helps improve our tutorials. And I hope you enjoy the rest of your evening. Thank you very much.